revision hip arthroplasty ده a very big subject, وانا I would like يعني to be useful ان انا I will talk in general just a few slides في الاول على revision hip arthroplasty، بس I will concentrate على arthroplasty او revision of acetabular components في حالات اللوسنينج. احنا طبعا دكتور وائل هيكلمنا على البيريبروستاتيك fractures، انما احنا if we try to summarize the indication of revision in arthroplasty, if we look into the registry, the Scandinavian registry, we will find that aseptic loosening, deep infection, dislocation, and fractures are the most common reasons for revision. In Egypt, I would think that they are the same, but the priority in our country, unfortunately, is infection. And this is one of the subjects that we need to concentrate in a special meeting just to try to avoid this serious complication. So in our country, I think infection is the main leading cause for revision, but still aseptic loosening also one of the very common reasons for revision. Dislocation also is a very dramatic reason for revision, and I will leave the periprosthetic fractures for Professor Wael Samir to give us an idea about it. So if we talk about loose prosthesis, which is the main reason in all registries, either cups or stems, they are very serious problem, and these are the most common reason for revisions. So if we take the acetabular component and the acetabular bone defects in hip arthroplasty, in revision hip arthroplasty, we will just enumerate the reasons and way of classifications and way of management. So these are not only in revisions, also it can be a problem in primaries, like this plastic hips like this. There is obvious, very difficult bone deficiency, but we will talk mainly about revisions. So in the difficult primaries, you will need some sort of more sophisticated investigations to identify the deficiencies. And you will need to have also special techniques to avoid the loosening of this problem. If we classify bone defects in revisions, it is a useful way to communicate between surgeons. It's a tool for preoperative planning, interoperative guide for reconstruction, and also good in research. So we have to have a good classification that is useful and known to most of the hip surgeons. A very nice, easy classification is the American Academy classification, which is classifying the bone defects into segmental deficiency, cavitary deficiency, combined defects, pelvic discontinuity, and type 5 is arthrodesis. This is a simple way of management. It gives you an idea how to manage. It is not the most commonly used in arthroplasty. The Paprosky classification is more commonly used, while this classification depends on identification of several points in the X-ray, plain X-ray, which is the collar line, teardrop, ischial lysis. All these items can be used to put the classification, which is the Paprosky classification, which is the most commonly used in the arthroplasty field. So it is classified into grade 1, which is usually very minimal bone loss, grade 2A, which is the superior medial bone loss, grade 2B, which is a superior lateral femur loss, grade 2C is medial wall violation, while grade 3, these are the difficult grades to manage, grade 3A and grade 3B with pelvic discontinuity and ischial osteolysis. If you concentrate on this classification, you find that this classification is made usually to be able to insert a cementless cup. It is a classification in the North American society, and the main idea was to how to use a cementless cup in these bone deficiencies. There is another classification, it's not well known. It is like a combination of the American Academy classification and the Bobrovsky classification, but usually a classification which is complicated like this, no one will use it. This is the extra classification. So if we have a acetabular deficiency, loose component, the aim of management is to have a full acetabular integrity and socket cover, to have a complete containment and fixation of the graft if we use it, complete fixation of new implants and stability, the creation of as normal as possible hip mechanics. You need to get the anatomical hip center and to have good cover for the graft and for the process. First, you need to exclude infection, especially in our country. Actually, excluding infection is very important to have good results, especially if you have loose implants after few years. So if you have a loose implant after 2 years, 3 years, 4 years, you have to exclude infection. And this exclusion of infection is not only by investigations. You have to have very good history taking. You ask the patient, how long did you stay in hospital? How long did you have antibiotics after surgery? How long was the wound oozing? This information you will build an idea if there was any infection, perioperative infection, like the long-term use of antibiotics after primary. You have a patient who had an arthroplasty and he will tell you, I was on antibiotics for 6 weeks. You have to think about that this might be infection. You have to do radiological studies. Usually, plain X-ray is enough to identify loosening, but it is not the enough investigation to identify the extent of loosening and the bone deficiency. You might need to have CT. Also, you might need to have ultrasound or MRI if you want to diagnose any fluid around, if you are in doubt about infection. So the management is, there is a lot of ways to manage bone deficiency and acetabular defects. These are points that we will try to analyze. So the first one, if you have osteolysis around a well-fixed prosthesis, especially cementless one, it is rare to see this, but if you have it, so sometimes you can get away with just filling this defect by bone grafts. It is rare to find this, like this X-ray. You can see the defect is here. So you can fill it with bone graft. How can you reach this? Usually you can reach it through removal of the liner and filling this defect by graft. So you can fill the graft, the defect like this by graft, and then you change the liner. There is a problem in this. It is rare, and also sometimes the locking mechanism of the liner will be destroyed after a while. So another way is to revise the acetabular loosening by another uncemented cup, all right? Usually you will find a bigger cup that can fit into the defect, and with or without bone grafts. But you will need at least 50% of contact between the host bone and the shell. So just revision by a bigger cup. Like this metal on metal loose prosthesis that needed just a bigger acetabular component with some morcellized bone graft. So this also very easy operation. It doesn't need a lot of hassle, just a bigger cup. Sometimes if the loosening is, or the bone defect is bigger than this, and the patient is old, and you are not planning to put any graft, sometimes use what is called a jumbo cup, which is more than 62 in size, and it involves just putting the very large cup snugly fit between the ischium, ilium, and pubis. Usually this technique is not easy. You need to remove more bone, and that's why we just use this in very elderly patient who is not, you just need to finish this operation as fast as you can. So there is no restoration of bone, and it is only restricted for elderly. You can use a block structural allograft, and this usually in the superior defects. So you ream to correct center of rotation until there is a contact between cup and the anterior and posterior wall. The graft should be inserted then and fixed, and it gives good initial stability, but if the graft it doesn't incorporate, sometimes failure of construct will happen. And actually, it is not the best way to reconstruct, especially in cemented implants. So this is a contained large defect, and it was treated by structural bone graft in the acetabulum, fixed by a screw, and then a cup was inserted. The problem with this, sometimes the graft is not taken, and it will be absorbed, and then the acetabular cup will be supported by nothing, and there will be loosening. It is good, especially in cementless prosthesis, what is called 7 graft, and we use it by this technique, like we put this graft and fix it by wires, and then we do the reaming, and then insert the acetabular cup, which is usually fixed by the graft till the host bone incorporate with the cup. The cup will be stable then. So this technique needs also at least 50% of contact between the shell and the host bone. Rarely used is a bilobed component. Usually 2 parts of this component. The superior part will be inserted in the bone defect, while the inferior part will be at the level of the hip center. So there is no also restoration of bone defects, and it is difficult to fit in large defects. We rarely use this in our country here. A very easy way to insert a stapler cup in hip revision is what is called high hip center. High hip center is not the best way to reconstruct, but it is reserved to elderly flail patient. The idea is try, if you are going to put the cup slightly higher than the anatomical hip center, try to avoid to put it in a lateralized position. Try to medialize as much as you can, because also there is a defunctioning of the abductor and usually patient. Like this X-ray that is inserted in a higher level. It should be at the level of the teardrop here, so the head is up here. And usually, if you have mediation like this, it will survive. But remember, this we had dysplasia of the acetabulum here. The hip was inserted lateralized and high, and in only 1 year, I remember. So I found this patient came to me with failure and dislodgement of the acetabular cup. So high hip center is not the best way to reconstruct. And also there is another way to construct it by counterhand. This is a way that you will need to avoid. Try to avoid reconstructing the acetabulum by bone cement, because this will not survive for few years, and usually you will have failure and it will be very difficult to revise. A very attractive method of reconstructing acetabular defects is what is called impaction graft. So it is a reliable initially stability by compaction of the graft. You try to put a morselized graft after containment of the defect. So if you have a contained defect, you can hammer small pieces of morselized graft, and by the compression, you find that this construct is stable to hold usually cemented cups, right? There is some studies that can be used in cementless cup, but it is not the standard. The disadvantage, it is difficult and needs a lot of experience, and also the limitation of bone grafts and the risk of transmission of the diseases. But it is attractive because it will build up the bone stock. So the technique, first, if you have an uncontained defect, you need to convert this segmental defect into a cavitary one. So you can use a mesh, and this mesh is helpful to contain the defect. And then there is a lot of techniques. This mesh needs to be inserted in a systematic manner, and usually it is not easy to use. And there is one trick that helps in success of this technique, is to avoid that any cement will touch the mesh, because any cement touching the mesh will unload the graft and it will cause failure. There is the characteristic of bone grafts used in this impaction grafting. It is usually fresh frozen morselized bone, either from heads from patient who will have total hip replacement, or heads from fractured neck of femurs in males to have good quality bone. The chips should be large chips, so you need to use this by manual extraction by nebular or whatever, the bone mills is not the best way to have grafts for this technique. Grafts should be from 5 to 7 millimeters in diameter, and you can mix by bone substitutes, but not more than 50%. You usually start by large impactors, and then you reach smaller ones till you reach the center of rotation. It is technically demanding, but very useful in young age. So you need to reconstruct the segmental defect into cavitary defect. This is a very obvious hip loose cup and pelvic discontinuity. So you need to treat the discontinuity by plating and use mesh to contain the defects. So something like this, and this is the X-ray after. Very difficult, but if it succeeds, usually you build up the bone stock for further revisions. Okay? So you use the mesh to make the segmental defect a contained one. And then you put the grafts in the floor here and try to hammer it as much as you can. And then you insert the cup. Impaction grafting results in the pioneers of this technique, either from the Netherlands or Exeter in the UK, they have very good survival, up to 98% in 10 years' time. But there is a critical factors. It is not simple, and possible pitfalls should always be kept in mind. Infection should be diagnosed and excluded. There is a lot of predictors for good results, which is the type of defects. All segmental defects should be contained, and impaction grafting, the degree of compaction is very important for stability. Also, one of the methods to reconstruct is to use the supporting rings. Molar rings, Berg-Schneider rings, Kerbel rings. We know all these metal rings are helpful to use with allografts to reconstruct acetabular defects. So a loose cup like this can be treated by a molar ring. So the graft will be down, then the ring will be inserted, and then a cemented cup can be used. It is not the best way to manage, and the long-term results of these rings are not very good. There is another way of acetabular reconstruction, which is called the stemmed acetabular ring, and actually this is part of my MSCH thesis, and we use this construct, which is a cup connected to the iliopubic bar by a stem, and the graft is put here. So you just try to be away from this weak area to be fixed into a strong area here, the iliopubic bar. And it is very good, actually, method, but it is technically demanding, and inserting this nail is not that easy and not without risks. Kerbel ring, also a useful method of a useful ring. It is low profile and can be used with morcellized graft or structured grafts, and it is not the very successful ring, because part of this ring will unload the graft, and this usually causes what is called graft resorption. So this is a Kerbel ring that can be used. You can use graft in this area and insert this, and this usually help in early mobilization in elderly. So it is not very difficult, but also the long-term results of these rings are not that marvelous. The new and very helpful method of reconstruction now is called the porous metal shells or trabecular metal, which is a porous material made of tantalum. It is used in the last 15 years. It enhances the initial stability of the cups. It improves structural reliability by resistance to fracture and failure, and also it is very favorable environment for bone remodeling and host bone ingrowth. It is very spongy. Bone from the host will go inside these grafts, which fills the defects. It is very useful. It is not without hazards. Also, there is a lot of talk now about how to revise if there is infection. So it is good as regard the availability, but also the price of these augments are very expensive. So there's a lot of shapes and techniques. There is also a lot of talks now about how to insert a cemented cup on these, and if you use a cementless cup, how to connect between these cups and this shell and this trabecular metal. Very useful to fill the superior posterior defects. You can use a cementless cup and you put cement in between the cup and the augments. And now there is a lot of talk about using this in a cementing cup with these augments. This is my late Professor Richardson in the oswestry that I did a lot of work with him about impaction grafting, and Professor Mahmoud Hafiz, and he was very helpful actually, very helpful in showing these techniques and following these techniques, and he had a lot of studies and papers about it. Revision is not the easy way of doing arthroplasty. Usually you have a lot of difficulties. You cannot sort everything. Sometimes a girdle stone might be the best resolution. It needs a lot of efforts, instruments, experience, and I think it should be done by arthroplasty specialist. It is not the general orthopedic way to do, and you have to have a very good learning curve. And this is also it is not only the revision. Some of the arthroplasties is not the usual for ordinary or general orthopedic surgeon, like this high degree of dysplasia. And وده دايما بقول ايه ان في ساعات ده عيان انا بشتغله وبعدين لقيت مكتوب عليه ايه الظلم سبب الانحراف، فهنحاول دايما نبعد عن الظلم علشان ايه يقل الانحراف. الف شكر. In summary, bone loss during primary and revision arthroplasty remains one of the most challenging problems facing hip surgeons. The aim is to restore center of rotation, replace lost bone stock. No one reconstruction technique is applicable to all cases. Hip surgeons should be familiar and prepared to a range of techniques to manage specific defects. Thank you.
Thank you so much, Professor Ayman Soliman, for this interesting talk. Thank you so much, sir.
أنا المتشكرين يا دكتور محمد،
العفو يا أستاذنا.
أنا متشوق بقى نسمع إن شاء الله دكتور وائل سمير إن شاء الله انا ما رضيتش to tackle any periprosthetic fractures or any حاولت ان انا يبقى التوك بتاعي ايه a little bit concentrating على اللوسنينج بس.
احنا لو في اي questions لسعادتك يا فندم we are waiting for any questions.
طيب انا مستعد لاي حاجه.
Any questions to Professor Ayman? طيب سعادتك معانا يا فندم، ودكتور وائل